Today, Dr. Jaknabayan Srinivas is going to start on. The problem is there.
Anna, occupant. Sir, Mohan sir. Mohan Mara sir.
నేను ల్యాప్టాప్ లేదు సెల్ లో కనెక్ట్ అని సీను
సెల్ లో కనెక్టరా మీకు నేను ల్యాప్టాప్ నేను సెల్ నుంచి కనెక్ట్ ప్రెజెంట్ చేయొచ్చా మొబైల్ నుంచి మోహన్ రావు సార్
మోహన్ రావు పంపండి ఒకసారి ల్యాప్ అది ప్రెజెంటేషన్
అది ఒకసారి ఫార్వర్డ్ చేయండి
మోహన్ రావు బిజీ ఉన్నాడు మోహన్ రావు కనెక్ట్ చేయలేడు
సార్ నేను మొబైల్ నుండి చేయొచ్చా
బషీర్ అడుగు
బషీర్ హలో బషీర్
రికార్డ్ పెట్టి వెళ్ళిపోయినట్టున్నాడు బషీర్ ఫోన్ చేయి
సరే నంబర్ లేదు సార్ నా దగ్గర నా డేవిడ్ ఏమైంది షేర్ వస్తుంది
సరే
ఫైన్ యా
ప్లీజ్
గుడ్ మార్నింగ్ ఆల్
Jaknabayan Srinivas is going to start on thrombocytopenia, which is very common in ICU. Now he is going to start a presentation like discussion on the case scenarios. I request Dr. Srinivas to start the presentation.
Thank you, sir. Good morning, all. This is one of the most common thing we see in our intensive care unit. But definitely we need to identify the cause and treat. So otherwise the prognosis will be very poor. Okay, the replacement of platelets is not the solution. We need to identify the cause. Next slide, sir. Sir, movement leda. Next slide. Next slide. Thrombocytopenia. Next slide, sir. Elthane unnandi. So thrombocytopenia. First thing is because of the decreased production. So where do we see decreased production? Because of the bone marrow disorder and liver diseases, or increased destruction or consumption. That is we see in primary and secondary ITP, DAC, TTP and HUS. Third is a dilutional thing. One massive resuscitation or transmission will give. Fourth is a redistribution. It is because of the hypersplenism. So these are the four causes we need to look into it when there is a thrombocytopenia. Either decreased production, increased destruction, or a dilutional or redistribution. Next slide. Okay. So how do I approach to thrombocytopenia? One is rule out pseudo-thrombocytopenia. So how do I rule out through pseudo-thrombocytopenia? Means you have to call the lab and ask them whether any clumps are there. Okay. Or this fluid is completely dilute. And look at the other cell lineages. The other cell lineages like how is WBC and how is the hemoglobin also. And we need to look into the peripheral smear of the patient. If required, we need to do a bone marrow. So what happens is, if suppose this thrombocytopenia is associated with anemia, then we can say it is a DIC or a TTP HUS or autoimmune disorders or nutrient deficiencies like folate, B12 and copper, or infections like HIV, HCV, or bone marrow disorders, MDS, leukemia, bone marrow infiltration by malignancy. If it is associated thrombocytopenia associated with leukocytosis, it can be a chronic inflammation, infection, or malignancy. Suppose it is associated with the three lines like leukopenia, anemia, and thrombocytopenia. Three are present, then it is called a myelodysplastic syndrome. or bone marrow infiltration or bone marrow disorders or leukemia we can see in these patients, aplastic anemia. Next slide, please. Yeah. So platelet transfusion. So mostly what we do is when the platelets is low, we tend to transfuse because there is a high chance that bleeding is a possibility. Okay. So one study has prophylactic platelet transfusion accounted for as much as 74% of platelet transfusion. So what should be the trigger of transfusion? Next slides. Yeah. So what should be the trigger of transfusion? This is by the international guidelines. It says that if a patient is stable, means suppose a patient with a dengue or some leukemia, aplastic anemia, sorbitol tumors, whatever is the cause, the patient is stable and platelets are less than 10,000 only, transfuse the patient. There is a chance of bleeding. Suppose this patient is having a fever, bleeding, okay, then you have to give this transfusion if it is less than 20,000. If suppose you have planned for a tooth extraction, elective surgery, endoscopic biopsy or lumbar puncture, then you should maintain more than 50%. Epidural analgesia should be more than 80,000, and operation of eye or CNS and cardiovascular system or massive transfusion, you have to target of more than 1 lakh. This is the standard guidelines we see in any hospital. Okay. So Anna, you don't move the slide. Here we need to discuss. Okay. I have totally, I think, 4 or 5 cases. Let's discuss and would like to take your opinion. A 26-year-old female, primigravida, 34 weeks gestational amenorrhea, was admitted complaints of fever and thrombocytopenia since 4 days to a local hospital, admitted to a local hospital. Dengue NS1 and IgM were positive and IgG was negative. At presentation, platelet count was 19,000. 3 SDP was transfused over 3 days as platelets were continuously less than 20,000. Still count decreased to 11,000. Patient shifted to our hospital for further treatment in view of refractory thrombocytopenia. At presentation, platelet count was 11,000 with petechiae on both lower limbs. What to do next? Sir, ఒక్కొక్కరు చెప్పండి సార్. ఏం చేస్తారు?
No, కాదు Srinivas. All the questions goes to Dr. Soumya because she's IDCCM student newly and she has prepared. So she'll be answering, otherwise others.
Yeah. Please, Dr. Soumya, you can take it, please. Dr. Soumya, you are available?
Sir, yeah, I'm online, sir.
Yeah, please. What will you do?
Please answer these questions, Dr. Soumya.
Yeah, sir.
Yeah. What will you do now? See, here you have in a nutshell, 34-year-old, 34-week gestation amenorrhea pregnant patient with 26 years old.
Yes,
and
sir.
dengue is positive, NS1 and IgM.
And
19,000.
Srinivas, if it is getting delayed, you can ask somebody else immediately.
Yeah, doctor, what will you do? So what are you thinking? The cause of thrombocytopenia and in this case, and how will you proceed?
Sir, other parameters are okay, sir. Like,
What do you want? Yeah. Tell
like
me.
how is our LFT?
LFT is mild, SGOT and PT is elevated 2 times and bilirubin is normal. Hemoglobin, hematocrit is around 45, hemoglobin is 15. WBC is normal.
Okay.
And there is no bleeding. Okay. And hemodynamically stable. Patient
Sir,
is conscious following comments.
I would go with further platelet transfusions.
Okay.
Because
So,
she's having PTK on the limbs.
okay. So what is your target? When do you transfuse with the PTK?
If the PTK or mucosal bleeding are there, if even platelets are less than 20,000, I would like to transfuse, sir.
Okay. This patient, so this dengue, when do you think this platelets will increase, or we should continuously transfuse for more days?
If the
See, dengue is positive, NS1 and IgM
yes.
is positive.
Yeah.
Yeah. So a patient having a fever onset, what is the pattern of dengue?
Like regarding the platelets you are talking, sir, you're
Yes,
asking me.
yes, regarding platelets only. Like when after the onset of fever, when the platelet starts dropping, when it goes into the
4 days of fever, the platelets will start coming down, sir.
Okay, then fever, once the platelets are coming down, fever subsides.
Yeah.
Fever subsides in the first
Because of
after
the
3 days.
consumption coagulopathy, the platelets will be decreasing.
So platelets will decrease, and after 2 to 3 days of lowest, it will start increasing on its own.
Yes, sir.
Okay. So this is a standard pattern of dengue. Do you want to investigate further in this patient?
If the patient is having the symptoms like PTK and any suggestion, any bleeding, ongoing bleeding, we will transfuse if it's less than 20.
No.
Otherwise,
So
less than 10, we will be transfusing.
No, doctor, I'm asking different questions. Do
Yeah.
you want to investigate this patient for any other cause of thrombocytopenia?
Okay. There is no evidence of any bleeding, then I would like to go check for the peripheral smear whether there is any hemolysis is going or any pseudothrombocytopenia is there. Yeah, I would like to look for HELP syndrome because she's 34 weeks pregnant.
Okay.
Also, there is a condition called a reaction between the baby and the mother, where antibodies against the platelets will be occurring in the mother. That also.
What is the condition called?
That's platelet antibodies, sir. I don't remember the name of it.
Okay.
But
So,
I read long back.
Thrombocytopenic purpura will be there. Basically, it will be more of purpura.
Sir.
Huh?
And it is not TTP, sir. Another condition where the baby bled.
Because of RH antigen, will have a reaction.
Yeah. RH antigen, they will develop platelet antibodies, the baby.
Yes.
That
so
also
most commonly, they see what in the mother they see is purpura is seen most commonly.
Yeah.
Thrombocytopenia. Okay. So this is a straightforward case of a dengue. I think what I would like to do is in this patient, if this patient has come to my OPD with a fever, and I have seen this patient with a normal platelet count.
Yes.
Okay? After that, I have seen this patient after decreasing the platelet counts. I don't need to investigate for anything in this patient. Okay, do you agree?
Yes, sir.
Suppose I see suddenly a patient coming to me with a 34 weeks gestation period and a patient having a thrombocytopenia of 20,000 and they are not mentioning any history of any thrombocytopenia previously or not having any other reports like 1 month or 2 months or this year. There is no CBP report. Platelets are I have not seen her report, previous medical record. I would like to investigate this patient.
Okay, sir.
Because we don't know, even though dengue is positive, I know next 2 to 3 days, this patient platelets will increase if I support this patient with a few platelets. Only here it is, there is a petechiae. So fever and petechiae, fever and bleeding is an indication for platelet transfusion.
Yes,
If it is less than 20,000, but here it is at present it is around 11,000 with petechiae on both lower limbs. I think we can wait also, not giving platelets, because there is no bleeding.
okay.
Okay, sir. Any other comments from anyone?
Yeah, one question to you, Anna. You mentioned fever is also indication for the platelet transfusion if it is less than 20,000. Fever will be there in dengue patients. What is the reason for the indication of platelets if fever is there?
No,
No,
this
what is,
patient.
David, what is the reason for?
Giving platelets for patient having fever.
No,
Okay.
usually what happens is when the platelets are low, the patient will not have fever.
Why patient flow? Usually the scenario is once the fever comes down in dengue, then platelets started falling, right? But sometimes you see the patient with suppose 18,000 of platelet and also fever is there 1 or 2. Is that the indication for giving platelets?
Yes, indication is there.
What is the
Because
reason for that?
no, these patients can become, if the patient is having a high grade fever, they can probably become a hemodynamically unstable, these patients. That is might be the only reason, or he might be thinking that if the fever is still present with the thrombocytopenia, some other reason might be there for the
Yes.
fever. Because usually in dengue, first 3 days it comes down. Satish sir,
No, I want
David, sir.
exactly.
Sir,
David,
can I add one thing, sir?
Yeah, Ramnadu, please.
Sir, actually, the thing is, whenever there is an alarming decrease in the platelets, before transfusion, first thing is we have to rule out whether any antibodies are there or not. Because whenever we are giving anything, then destroying means something is destroying at faster pace. So we need to rule out the antibodies first thing. And another thing is we are more worried if it is less than 10,000 spontaneous intracranial hemorrhage. For that only we are giving transfusion. Otherwise, remaining, if you transfuse more, they will be destroyed more. Even in dengue also, why we put transfusion threshold as less than 10,000 is just even if you give platelets, it will delays the recovery of the platelets. That's why we will not give. And less than 10,000, why we are preferring is to prevent the spontaneous intracranial hemorrhage. Maybe.
Ramnaidu,
Are we giving or not giving, sir? Ramnadu garu?
Sir, in this case, 11,000 workup parallelly have to be done, but at the same time we have to arrange transfusion because 11,000 is
But not transfuse.
Sir,
Ramnaidu, what antibodies you will check in dengue?
antibodies, no, sir. Actually, if it can be coexistent with dengue also, but the days of the fever is also very important, sir. Here it is day 4. But the thing is, if it is day 10 and all, then we need to search for the antibodies.
Yeah, definitely. Then we have to search for other reasons.
Yes,
But
sir.
in this case, typically day 4 thrombocytopenia NS1 and IgM is positive. So typically it is a dengue positive case. By my question actually exactly that what is the reason for giving in patient having fever?
Actually, in
What is the
fever,
relation? Fever and
actually.
platelets transfusion.
Actually, in fever, there is no indication to transfuse
He
platelets.
mentioned that's why. Chekina? దానికి
Yes,
రేషనల్ ఉందా?
So if a patient is having a fever high grade and bleeding is there, definitely is an indication.
If bleeding is there, it's okay. No, nobody will
Fever, yes.
say no. But
We are not talking about bleeding. Only fever with
Fever. Yes, sir, fever.
thrombocytopenia. Do you give? Because if the reason is logic, as per Ramanadu says, is it because of the expecting that once the fever comes down, again platelets will come down for prevention sake you are giving, because the target from 5,000 you are increasing to 20,000, or what is the reason? I think just want to, am I right, David sir?
Yes, sir. Fever is a alarming sign for giving platelets. Exactly. I don't know what is the rationale. Fever is causing any further deterioration of platelets.
David sir, I'll check it and I'll post it by evening.
Okay, sir. Sure.
Right.
Because
Already 20 minutes over, Jekina. So
Sir,
don't.
next slide.
go
Next
to-
slide,
go
sir. Sir, next slide.
Okay.
Next slide, sir. Yeah. So basically, a lot of platelet transfusion were given. Platelet transfusion should not be done in the management of dengue because it doesn't prevent severe bleeding, time to cessation of bleeding, and associated with a lot of significant side effects. Next slide, sir. Sir, next slide. David, sir. Yeah. So prophylactic, as we already discussed, less than 10,000 unless there is an absence of bleeding. Next slide, sir. Next slide. Next slide. Yeah. Second, 1 second. In this, yeah, next slide, sir. So the 48 hours decreased up to 9,000, but gradually improved and patient was discharged at day 5 with a platelet count of 50,000. Next slide, sir. First weekend. Second weekend. 45-year-old female diagnosed case of ITP. Okay. Post splenectomy status. Fever, cough, expectoration, shortness of breath, 76% on room air. SpO2. It was connected to HFNC, 30 liters per minute. FiO2 of 0.5. Saturation improved to 96%. CVP shows WBC of 4,200 and platelets of 5,000. What's the next steps? Sir, Japandi. Doctor, Japandi.
Yes, sir. Yes, sir.
What will you do now?
Sir, I want to evaluate whether she is having any pneumonia because she's having fever with cough and expectoration with decreased SpO2 and which got improved with the HFNC.
Okay.
And she is a post-splenectomy status, so her she's immunocompromised. I don't know whether she has taken any pneumococcal vaccine before splenectomy.
Okay.
She would have been taken. So I would like to go for imaging and confirm whether she is having any pneumonia.
Okay, she is having already right middle zone and lower zone consolidation is present. Okay. So what will you do for platelets now? So I am maintaining on HFNC. If required, I'll intubate or I'll put on NIV. I'll look into that things. What will you do for platelets? I started an antibiotic and the routine stuff will do it.
Platelets, CBP shows, okay. I will transfer, sir, less than 10,000.
Any specific therapy?
ITP.
Any specific therapy?
Specific therapy.
Madam, here he mentioned ITP.
Yes, sir.
What is the reason for falling platelets?
ITP, they'll have antibodies against the platelets in their blood.
Okay.
So, if you give platelets, if the patient is alarming, so we need to give platelets. Otherwise, we should go with the IVIG, sir, because it is ITP.
Okay, fine. So any other thoughts?
For IVIG or any alternate for that?
There are other drugs like azathioprine, like DMRDs can be given, but still now at present she is having a pneumonia. So I would like to go with steroid or steroid. Steroid will be the first drug of choice. Secondly, IVIG.
Yeah, Satish sir has already put an answer as steroid. Let's go, Anna. Let's go forward.
Forward?
Yes.
Steroid is there.
Steroids istara, Satish?
ఇవ్వాలి.
Yes.
If patient is not having any pneumonia,
Sir, at least normally sometimes we might require pulse dose, but in this patient, maybe we go with it's 1 milligram per kg body weight may be helpful, sir.
1 mg per kg will help Anna in ITP.
Will help, sir.
Yes, sir.
If the patient is otherwise, there is no contraindications for pulsing, we can pulse the patient. Otherwise, at least 1 milligram per kg body weight, which is fit into even hemodynamics, fit into severe community acquired pneumonia.
No,
whatever
my question is not
Yes.
for hemodynamics or test dose. My question is not for pneumonia. Can you give 1 milligram per kg will help for ITP to improve the platelets?
Yes, it will help.
I want evidence.
Yeah, I will send you.
Okay. Thank
I will
you.
send you.
Yeah.
Next slide. Now. Next slide. Next slide. Anna. So this there is no role of platelet transmission in this, unless there is a bleeding in ITP. So first line is, as Satish sir mentioned, steroids. Dexamethasone 40 milligrams for OD for 4 days, preferred over others. And second line is cyclosporine, cyclophosphamide, azathioprine. The other IV immunoglobulins are the next line of therapy. So this patient, next slide. Start on methylprednisolone 500 mg IV OD. Platelets improved after 3 days, and patient was discharged on day 5 with a platelet count of 11,000 and continued on steroids. So this is another patient, third vignette. 45-year-old male RTA, fracture right femur, underwent open reduction internal fixation. Post-operative course uneventful. Came back after a week for suture removal. Some pus from the wound site. Sent for culture sensitivity. Started on antibiotics. Wound discharge increased over next 2 days. Vac dressing placed. Day 4 hospital stay. Patient developed thrombocytopenia with digital cyanosis and right upper limb and HB of 9. What's the diagnosis and next step? Chepandi. Doctor, start చేయండి.
Sir.
చెప్పండి. Here the clue is thrombocytopenia and digital cyanosis.
Yeah.
Day 4 admission, hospital admission. Probably on is sick.
Should I think? Is he developing DIC, sir?
Okay. DIC. Any other diagnosis? Differential?
It is not. It is not. Is it hit, sir?
Yeah, one more differentials. Okay, hit is a possibility. DIC is a possibility.
Any sickle cell crisis? If he sickle cell anemia is there.
No history.
Madam, patient having fracture femur, but he developed digital cyanosis of the right upper limb. He said he is given, that is the clue for diagnosis.
Okay. Embolism, fat embolism. But why in fingers?
Fat embolism, does it cause right upper
Only
limb?
right upper limb?
No. Anywhere it can cause, sir. Why right upper limb?
Anybody?
Usually fat embolism we see more in the lung with an ARDS pattern.
Yes, sir.
So this is digital cyanosis is something happening with the arterial system. So we have two diagnoses. One is DIC is a possibility, and second is it is a possibility. Okay.
Yeah.
Both. So how do you diagnose it?
DIC?
Yeah, both. See,
By the,
these both are
yeah.
the differential diagnosis.
Yeah, HIT is like if he received any heparin, and
Tell me,
within
give
5 to
me,
10 days it will be after
no,
receiving.
no, give me,
Sir,
tell me one test which can differentiate these two. DIC and HIT.
sir, serum fibrinogen levels, D-dimer.
Any other thing? Sir Satish has mentioned PF4.
Yeah, PF4. Yes.
Any
That
other
will,
thing? Some quick test. In one type of disease, it will not derange. Other disease may derange.
yes.
What is that? PT, APTT, INR.
Okay.
That will not derange in HIT.
Yes, sir.
Okay. That can be normal, and most of the times it is when the platelets are low, it can be deranged in DIC, usually because all the factors will be consumed. Because
Yes.
PF4 takes time. Any other things? I think remaining things will be normal in this. So Anna, next slide, please. Okay. So we all know that so this day is fourth day, he has mentioned specifically, day of hospital stay. So what happens, heparin-induced thrombocytopenia, when you give a heparin, then this goes and couples with PF4, and antibodies are produced and formed an immune complex, and which can cause platelet removal by splenic macrophages, and macrophages, and thrombocytopenia, platelet activation, and leading to thrombosis, and also release of procoagulant microparticles, and then leading to thrombocytopenia. Okay, so there is no role of platelet transfusion unless there is a ongoing bleeding, and there are scoring systems. Next slide, sir. There are few scoring systems for HIT. Will not go into details on this. So I think next slide. Next slide, sir. Next slide, sir. Yeah. So the parenteral agents such as ergotrobin, bivalirudin, danoperoid, and fandoperax can be used, or a direct oral anticoagulant like dabigatran, apixaban, rivaroxaban, edoxaban can be used in these patients. So anticoagulation for at least there is an arterial or venous thrombosis, we need to give at least for 3 to 4 months in these patients with the oral anticoagulants. But in ICU, you can convert these into a parenteral drugs, and when patient is getting discharged, you can go into the oral agents, anticoagulant agents. So platelets are basically in this HIT. If you give platelet transfusion, it is a risky. There is a high chance of thrombosis, and mortality also is very high. So platelets are primary mediators of hemostasis. There is emerging evidence to show that they may also mediate pathological thrombogenesis. So national-wide inpatient sample to evaluate the current in-hospital platelet transfusions and their association with arterial venous thrombosis and MI, stroke, and in-hospital over 5 years. These data suggest that platelet transfusions are common and likely administered to sicker patients and those with clinical bleeding, and is associated with higher odds of arterial thrombosis, but not venous thrombosis, and mortality among hospitalized patients with a diagnosis of TTPI and heparin-induced thrombocytopenia. Okay, so this patient started on fondaparinux, platelet count increased gradually, and the patient was discharged on day 5 and having. Okay, so that to be, as patient is having thrombosis, we need to continue for at least a few days, 3 to 4 months. Next slide.
Now here Fondaparinux 7.5 milligrams is given. This is the actually treatment dose, therapeutic dose. What is the reason for giving this high dose?
Which one? This is because there is
Fondaparinux.
also this one arterial thrombosis is there, no?
Okay. So they have started therapeutic dose.
It is not the DVT dose.
Okay.
Yeah. Vignet 4.
కాదు ఇంతవరకు ఉన్న వాటిలో సీను
Sir.
ఓన్లీ నువ్వు నేను సతీష్ డేవిడే మాట్లాడుతున్నారు. వరలక్ష్మి రాణి మేడం ఆ సీనియర్స్ ఎవరు మౌనంగా ఎవరు మాట్లాడలేదు. అడగండి ఒకసారి.
Let them take this case, sir. A 40-year-old female admitted with dengue NS1 and IgM positive. Clinical condition improved, platelets increased from 20,000 to 90,000. On day 6, she again started developing anemia, thrombocytopenia, and altered sensorium. Anemia, thrombocytopenia, and altered sensorium. Peripheral smear shows cystocytes. And day 7, her platelet count again was 7,000 and developed the epistaxis. What is the diagnosis and the next step?
HTTP. What?
లేదు ఇంకా వేరే వాళ్ళు చెప్తా ఉన్నారు కదా సార్. మోహన్ సార్.
HTTP, sir. Yes.
Yeah, okay, fine. So here all the characteristic features are there. Next slide. This is a thrombocytopenia, anemia, thrombocytopenia, altered sensorium. Is present. 3 are there. We need to check fever. Is there this? Positive. Probably fever not mentioned. Can have a don't need of high grade fever. Can have a low grade fever. Madam?
Read on Bharat Payant. Sorry. Thrombocytopenia, microangiopathy, hemolytic anemia.
ఇలాంటి కేసులు ఓపీడీలో మెహతాజీ ఎక్కువ చూస్తుంటాడేమో.
Okay, Anna, continue. Next. Hello?
Hello?
Continue.
Yeah. So thrombocytopenia, microangiopathic hemolytic anemia, neurological abnormalities, renal failure, and fever. So this renal failure may be mild to moderate renal failure. Suppose if it's a HUS, it will be mainly renal failure will be more, and if it's a TTP, there will be altered sensorium will be more. So there is no role of transfusion.
So the differentiation between the HUS and TTP is the renal failure and CNS involvement.
Yes.
Why can't it be a CSN involvement with HUS? Can you rule out by these two?
Sir, this is a spectrum, sir. This is
a spectrum, but what is the specific? What are any specific investigations for rule out HUS and TTP?
Yeah, I would like to go with Adam TS13 testing. And
differentiation of HUS and TTP.
Sir, HUS is a triad, sir, and TTP is a pentad. They'll have this.
Chappan, madam, please explain.
Sir, hemolytic anemia, renal failure, thrombocytopenia. These 3 are the triads, sir. And fever and neurological manifestations, if they get added, it is called pented, sir, which we'll see in the TTP.
I'm asking what investigations you do to rule out, I mean, differentiate.
In the HUS, there are atypical HUS, typical HUS is there, and diarrhea-induced HUS is there. Diarrhea-induced HUS, we look for a Shigella like toxin, E. coli, and clinical symptoms of loose motions are there. But atypical HUS, it can be complement mediated or complement mediated. In TTP, we will look for Adam TS 13 levels.
Okay. Anna, next,
Yeah.
for next.
1 second.
Okay.
Plasma patient transfused 1 SDP for ongoing bleeding, started on plasmapheresis, improved well after 4 sessions. 5. Next one. Anna, next one. 25-year-old female primary gravida had an IUD. Okay, membranes were intact. So start on oxytocin, Foley's bulb dilated, OS attempted, but fetal products were not getting expelled. DNC attempted, unable to remove the products completely. Patient started to have uterine bleeding, emergency hysterectomy done, and products removed. So what might be the cause of thrombocytopenia in this? Patient platelets are around 30,000.
Yes. Sir, she developed thrombocytopenia post-surgery, sir?
Yes. No. Pre-surgery only.
Okay. Sir, as I said, the baby group and the mother group are different. RH was different, and the antibodies against the platelets will be forming. It's a condition.
So it's again a possibility, strongly it's a DIC. Okay.
DIC. Okay.
DIC in this patient. So in this DIC, so can we know what products to give at what time? Like, can we do any test and look into what products we can give? Whether we can have like if there is any fibrinogen deficiency or coagulation factor deficiency, platelet deficiency, or excess fibrinolysis, is there any test to look into it?
Fibrinogen levels, sir.
Okay. Any test, one test, we can do all these things?
One test. PT with INR and APTT, sir.
How do you look into fibrinolysis in that?
That we can't look into that, sir.
So which test you see coagulation factors, fibrinogen and platelets and fibrinolysis? See, coagulation factors, we can do PT, APTT, INR, and fibrinogen directly we can measure fibrinogen levels. Platelets, we can measure platelets levels. How will you check the fibrinolysis?
FDP's fibrin degrading product, D-dimer, sir?
Any other test we do specifically in, hope it is there in a care hospital, because sir used to do a lot of transplants, liver transplantations. Mohan sir. Hello. He used to do a lot of
Thromboelastogram.
Yeah, yes, sir.
OTM. Okay.
Okay. Next slide.
Yes.
Anna, here why can't it be why can't you rule out that antiphospholipid antibody syndrome?
This
thrombocytopenia.
And this
Young lady.
patient, see, this patient is clearly, it is showing like a patient, this one, hysterectomy, low platelets. It more looks like a DIC, bleeding, all these things.
Yes, but
Yeah,
initially patient, yeah, but patient already developed thrombocytopenia, no?
it develops thrombocytopenia because of bleeding.
Yeah, before bleeding, and because of IUD, can't we rule out that this thing, that autoimmune disease,
We can
for
do sir, that also. We can do.
thrombocytopenia? Yes. Next slide.
So there are a lot of causes for.
What is the best Rotem or TEG, Dr. Jakina?
Rotem is latest, sir. Rotem.
What is the best out of both?
Rotem, sir. అంతేనా?
కేరళ వాడుతున్నారని విన్నాను నేను ఇంతకుముందు అండగా చెప్పినప్పుడు తెలియదు అందుకు అడుగుతున్నా.
Rotem is the new one, and it will give almost everything.
ఈ టెగ్ కూడా ఇస్తుంది
వస్తుంది కానీ బట్ I heard one presentation, a very good presentation from the Rajesh Apollo. The difference between these two and what tests can be done more in Rotem than TEG. TEG is a initial means and low cost, and Rotem is having everything. Some more tests also, but exact difference I don't know.
No, TEG also is having some advantages. Rotem is having some advantages.
Yeah.
Not able to remember. TEG also will show all these phases.
ఫ్రెష్ మరి వరలక్ష్మి మేడం అని చెప్తుందేమో.
Varalakshmi. Okay, we'll see.
Hello.
Madam.
Hello. Sir, అది రోటంలో అయితే లైక్ టెక్లో జస్ట్ యూ జనరలైజ్డ్ అంతా గ్రాఫ్ వస్తుంది దాన్ని బట్టి యూ అనలైజ్ బట్ రోటంలో అయితే యూ కెన్ డూ స్పెసిఫికల్లీ ఇఫ్ హెపరిన్ ఇండ్యూస్ అది చేయొచ్చు పర్టికులర్లీ ప్రెగ్నెన్సీనో ట్రామానో అలా ఉన్నప్పుడు when you suspect fibrinogen levels are low, symptom specific rotem low, which you can't do in TEG.
Yeah, and also to differentiate
Specific, like sir, what do you call them?
it's also do extem and item, madam. Extem means external pathway and internal pathway, intrinsic pathway. So that can't be done in TEG.
Yeah, అలా డిఫరెంట్ గా చేయడానికి వస్తుంది.
కొత్తగా టెగ్ లో కూడా మీకు ఫ్యాక్టర్ అదే తగ్గట్టు మారే కొత్త వర్షన్ వచ్చేసింది సార్. సో యాజ్ ఆఫ్ నో బిగ్ డిఫరెన్స్ బిట్వీన్ టెగ్ అండ్ రోటమ్.
ఒకసారి పోస్ట్ చేయండి శ్రీనివాస్, ఒకసారి ఆర్టికల్.
రైట్ సార్, రైట్ సార్, డెఫినెట్లీ.
డిఫరెన్సెస్ ఓల్డ్ వన్ న్యూ వన్ డిఫరెన్స్ ఒక టాబులర్ లో చేసేస్తే
రైట్ సార్, రైట్ సార్.
సో నెక్స్ట్ slide please. Next slide. Yeah, we also need to look into the drugs which can cause thrombocytopenia: sulfonamides, beta-lactams, trimethoprim, NSAIDs, disease modifying anti-rheumatic drugs, immunosuppressants, anticoagulants, diuretics, even the pantoprazole, less of ranitidine. So these are also has to be drug induced thrombocytopenia has to be looked into it. Next slide. So structured approach to a patient with thrombocytopenia is very important. Platelet transfusion may not be useful in destructive or consumptive causes of thrombocytopenia. Only indication for transfusion in such patients is ongoing bleeding. Look for even other causes of coagulopathy in all bleeding patients. Unnecessary transfusion increases the length of stay and may even increase the risk of arterial thrombosis in HIT and TTP. Alternative regimen should be used based on the primary diagnosis. Next slide. Thank you for not transfusing platelets without evidence. Thanks all. Any questions, please?
Thanks, Anna. Very nice presentation. You mentioned almost all the cases what we are seeing in ICU. Sometimes unable to differentiate the diagnosis. Just giving platelets because platelets are low. Unless you diagnose the patient, depends on the clinical criteria and lab findings. We have to ask for some more investigations to differentiate instead of giving platelets. Otherwise, patient is having bleeding. You have must be very careful in giving the platelets. It causes so many complications of rally and further falling the platelets and worsening of the patient. So it's a very useful topic and very nice
David sir,
presentation. Sir.
For everybody excludes, I mean, తగ్గిపోతున్న జనాలు క్లాస్ అయిపోయింది అనుకోని విష్ హ్యాపీ బర్త్డే టు అంబటి మోహన్ రావు.
Oh, happy birthday, sir. Mohan Rao, sir.
Happy birthday, sir.
Thank you, sir.
Happy birthday, Mohan sir.
Happy birthday to Mohan Rao and Dr. Chandana.
Oh, Chandana, happy birthday.
Chandana also.
హ్యాపీ బర్త్డే చందన.
Happy birthday, Chandana also.
Mohan sir, happy birthday. Chandana, happy birthday.
Thank you, sir. Thank you.
Sir, regarding platelets, Srinivas sir, Jakina,
Sir, madam చెప్పండి.
చిన్న డౌట్ ఏంటంటే when we do platelets, like మనకి even before we know the cause, exact cause, అంటే the trend, how drastically it's dropping down, like today, like yesterday I have seen 60,000, today I have seen 20,000, and my primary consultant, she won't wait. She says, no, it's going down and I can see small petike. I want to give transfusion and estero. Do you not face such situations?
Many face situations, madam. ఎందుకు ఫేస్ చేయం మేడం? అందరం ఐసీయూలో కదా పని చేసేది.
అలాంటప్పుడు is it the actual number, actual figure, or is it the trend, how fast it's dropping and you see petechia or you see subconjunctival small petechia or hemorrhages? At that point, will you not be saying okay for transfusion?
Well, actually, we are seeing 60,000 and 2,000 కూడా పడిపోయినాయి. ఇది మన ఓవర్ ఎ పీరియడ్ ఆఫ్ జస్ట్ 24 hours. So definitely, madam, ఎందుకంటే 10,000 is the trigger as per WHO or even Indian guidelines also. Actually, Telangana government last time during dengue season, they have issued a guideline saying that less than 10,000 only you give platelets. Otherwise, you should not give platelets, and they educated the public also.
For that, how many times we have to check platelets? Suppose today 15,000, suddenly next day morning, next day you are doing, next day it is 5,000. By the time patient started bleeding, then attendants ask, why you didn't give, at least you didn't ask me to arrange. Now you are telling bleeding is there, you get platelets urgently. So how frequently you will check platelets in that condition?
So we are checking twice per day, sir. Suppose if it is very low, less than 10,000, we are checking 3 times. Otherwise, 2 times, more than 10,000.
Yes. If downtrend is there, better to check.
And what we do is early morning 8 o'clock, we get a platelet. Even though we get a platelet count at 8 o'clock, at 9 o'clock we call the pathologist and we find out how is the platelet, any platelet clumps are there or anything, or what is the true thrombocytopenia.
Yeah.
And again we do it usually at around 3 o'clock, because before they leave, they will again see the peripheral smear and they tell us. So I think a close contact with pathologist and looking into smear is very, very important.
You will ask pathologist for mature platelets and immature platelets.
Yes, sir. Yes, sir.
Yeah, because mature platelets are their number is increasing, then we can wait because platelets started improving. Mature platelets, so that time also we need not transfuse.
Yeah.
Patient temperature, pH, calcium level should be adequate. Etana, what you are trying to tell? Satish?
Hello?
Type chese ఏంటది?
The indications for fibrinogen transfusion in any patient with PPH or DIC. Just for other people.
Okay.
David sir, just one point, answering to your question previously. Fever with thrombocytopenia ఉన్నప్పుడు ఎందుకు ఇవ్వాలి అనేది. So the theoretical point was fever ఉండేటప్పుడు activity of platelets decreases. So number ఎక్కువ ఉన్నా సరే bleed అయ్యే ఛాన్స్ ఎక్కువ ఉంటుందని ఇస్తారు. During fever, high grade fever.
So if it is less than 20,000.
less than 20,000 ఉన్న యాక్టివిటీ తక్కువ ఉంటుందని చెప్పి ప్లేట్లెట్ ట్రాన్స్ఫ్యూషన్ ఇస్తారు. అంటే there are more chance of bleeding అని చెప్పి. So that is a theoretical point. ఎక్కడ I mean as proven కాదు.
Sir, my practical observation, sir, I have to get platelets from Jubilee Apollo, which takes at least 4 hours for me to get the platelets. So our frequency of testing platelets is every 6 hours if it is rapidly falling. If it is slowly falling, twice a day. So my consultants are a little bit scary, saying that now it is already 20,000. After 6 hours, we'll repeat, it will come down to 10,000. Then it will take 6 hours to get the platelets. At that point of time, it might come down to 5. So our threshold, they have increased. They are putting at 20,000 and immediately we'll ask for a platelet. That's why practically we follow because of the time frame.
Yeah, true, Satish Garu. Endukante all these guidelines, they are formed somewhere else where they have in-house blood banks and everything. So products are readily available. When you see the low number, immediately they'll release. But for us, it takes time, hours and hours. Morning chepte evening ki kuda ravu okkosari. So
another problem also is there, madam. At 20,000, if you ask to arrange the platelets, they have arranged platelets and next day platelets improved to 50,000 and they are asking to transfuse because they have arranged. So this type of so many issues are there, but
yeah, this is all basically practical issues which will not be there in the guidelines. Yeah.
Guidelines undadu kada.
Jekina, one question. When you are transfusing platelets, is it group specific is needed or not? Is there an advantage with giving a group specific platelets?
Sir, we actually give group specific platelets, but we also there are specific. See, this is because the reaction is with some remain WBC ఏమన్నా ఉన్నాయేమో అని దాని వల్ల reaction, not with the platelets. So that's the reason why we give a group specific, sir. But without group specific also they can do it, SDPs. That I think it will cost a little higher price.
Yeah.
So when you are giving group specific platelets, we can expect more platelets to raise compared to non-group specific.
లేదు సార్, దానికి సంబంధం లేదు సార్, దానికి సంబంధం లేదు, ఓన్లీ రియాక్షన్స్ సార్, రియాక్షన్స్ కోసం అని.
They have some antigens.
Only reaction
will cause
అంటే means if you are non-group specific gives some conditions, there will be more destruction of platelets compared to the group specific. Somewhere I read.
Sir, basically because of WBC అంతా ఫిల్టర్ కాకుండా ఉంటదని చెప్పేసి సార్, అంతేగాని ఇది నా ప్లేట్లెట్స్ కి గ్రూప్ స్పెసిఫిక్ అవసరం లేదు.
ఫైనల్ కాజ్ కూడా అదే అయ్యుండొచ్చు కదా సార్ మోహన్ సార్?
అయ్యుండొచ్చు.
అదే కదా, దట్ ఈస్ ఆల్సో రీజన్ ఫర్ ఫాలింగ్.
Jekina sir, on the first case, pregnant lady 3 days transfusion గురించి చెప్పినప్పుడు I think one more point we can add is the platelets are not increasing with the transfusions. We have to think of Adam TS13 ఒకవేళ feasibility ఉంటే. సో అంటే Adam TS13 కానీ లో ఉంటే so it will decrease. So the treatment is giving cryo rather than platelets.
So basically I did not tell that. Even not only that, even any dengue patient, we can try with the cryo also.
Yes, yes. And it is based on Adam TS30. If it is low,
cryo or FFP can be given. Okay.
అంటే నార్మల్ గా అదే ఇవి చేసినవి ఏంటంటే Adam TS లో ఉంటే they'll respond with cryo. Because you are replacing the same thing.
అదే క్రయో ఉంటే క్రయో ఇవ్వచ్చు, లేదు అంటే FFP కూడా ఇవ్వచ్చు. బికాస్ ఫైబ్రినోజన్ ఉంటది కదా దాంట్లో.
Yes, sir.
So dengue patients, they mentioned it specifically in dengue.
మనకి సెపరేట్ గా వాన్ విల్బ్రాండ్ ఫ్యాక్టర్ దొరుకుతుందా?
Yeah, it is available, madam.
No, madam, commercially available. Cancer patients they are giving, no? Hemophilia.
It is available.
There are no more questions. We will close the session. Jakina sir, very nice, very useful presentation.
Nice presentation, Jakina.
Discussion also very good. And happy new year to Mohan Rao sir. There will be a huge celebrations in Medicover Hospital.
Thank you.
Jakina,
Thank you
please
all
share
for
the
your
presentation.
active
Please share
participation. Thanks.
Active
Thanks,
celebrations are
Srinivas.
going on. Anybody can attend. Wait, sir.
ఫ్లైట్ చార్జెస్ ఇస్తారా మోహన్ రావు సార్?
మా హెచ్ఓడి లేరు సిటీలో.
ఫ్లైట్ చార్జెస్ ఇస్తే మేము ఇస్తామండి సాయంత్రానికి.
కాదు, మా హెచ్ఓడి లేరు సెలబ్రేషన్ చేయడానికి.
సరే,
ఓకే సార్, బాయ్ సార్.
సండే బాంబే వస్తున్నారు ఎవరన్నా?
మోహన్ సార్ వస్తున్నారు, మోహన్ మహారాజ్ గారు వస్తున్నారు.
ఎందుకు?
టీచర్స్ కాన్క్లేవ్ అంటే
టీచర్స్ కాన్క్లేవా?
ఐడిసిసిఎం టీచర్స్ కాన్క్లేవ్ సార్.
అవునవును, వెళ్తున్నారా సార్?
మోహన్ మహారాజ్ గారు వెళ్తున్నారు.
మీరు వెళ్తున్నారా సార్? సతీష్ సార్?
నేను వెళ్తున్నాను సార్, సండే కదా.
ఓకే సార్, థ్యాంక్ యూ. విల్ క్లోజ్ ద సెషన్.